Hi, my name is Jasmine Solis. I'm an MFT6102. This is my week 5 assignment, providing a diagnosis. The movie that I chose to do my diagnosis on is The Aviator, starring Leonardo DiCaprio. This is regarding the life of Howard Hughes. Professor is Sutton, Asha Sutton, and today is December 31st, 2016. From a young age, Mr. Hughes's mother would consistently teach him that he had to wash his hands often to stay away from people because they were filled with germs. She had a fear of germs and him getting sick, so she would often teach him that staying away from them was the best thing and teach him the word quarantine. This was a word that he later used in life to help calm him down during any attacks that he may have had. Mr. Hughes had a fear of others touching him, not so much touching him, but touching his food, touching his drinks. If they poured something for him, he'd have to see it and it'd have to be right done in front of him. Otherwise, he would order like a glass of milk, but he would order it in a bottle and it'd have to be closed so that he can open it himself in a specific way. And it would be a consistent ritual that he would do when it came to drinking milk, which he ordered consistently. The doorknob, he would not be able to touch a doorknob in a bathroom after he'd wash his hands. Excessive hand washing, he'd carry with his own soap, the same soap that his mom used when he was younger, and also using the same case in which his mom used as well when he was younger. And he would consistently wash his hands in a specific manner, where he would kind of do it like this and just make sure that he got everything around his hands. He would use the paper towel or the cloth that was on the side to dry his hands. But he would not touch the doorknob if he didn't have a napkin to open it with. These are the things that he was exhibiting to others and was showing his signs of OCD, which is his diagnosis. I diagnosed him with OCD with absent insight, delusional beliefs, and tic-related as the primary diagnosis. And his rule-out diagnosis is specific phobia disorders, situational. He suffered from delusions where he would look at running water coming from the faucet, even though there was nothing there but the water. He saw something that frightened him, and he would often ask if that looked clean, because he saw something that no one else can see, and he would have to be reminded by whoever was with him that there wasn't anything there, so that everything would be okay and he can go ahead and proceed with his the next step of what he needed to do, whether that be wash his face or wash his hands or whatever the case was. These things were manifested because of his obsessiveness with germs, and that started from when he was young. So he would, in continuance with those aspects of what he was doing every single day, and then the delusions. When it came to the phobia, the specific phobia disorder, he wasn't afraid of any type of heights or anything like that, or animals or anything. He was more afraid of someone being ill and passing it on to him. Anyone who posed a threat in that manner, where he felt they could contaminate something that he was going to consume or something that he had. He was never particularly worried about his own appearance, because he was always well taken care of. His clothes was always well taken care of, and if he had anything on it, he would clean it consistently until it was gone, and put that much time into it. If he was dealing with any kind of business with anyone, he would see something, some type of flaw on that person, he would stop what he was saying and focus only on that flaw and inform the person of the flaw and to remove it, so that then he can proceed. Until that was done, he was not able to move forward with what he was saying or what he was doing. He would be a complete standstill until that person removed that particular object off of their clothing or out of his sight or threw something away in a manner that he directed them to do so. Once that was done, then he'd be a little bit more comfortable and he'd be able to proceed on to the next thing, just like a light bulb. Turned one on, turn it off that quick. The diagnosis with OCD with absent insight, delusional beliefs, and tic-related, I used an ICD-9 code of 300.3 and an ICD -10 code, which is also F42.2. His rule-like diagnosis, I used ICD-9 code 300.29 and ICD-10 code F40.248. Mr. Hughes' diagnosis with OCD with absent insight and delusional beliefs and tic-related, he did display obsessions as defined in 1 and 2, where there were reoccurring and persistent thoughts, urges that he experienced during the disturbance as an intrusion or unwanted, and which would cause him anxiety and distress. It would completely immobilize him from doing anything productive for that moment. He would show signs where he would attempt to ignore or suppress those thoughts, but until the actions were cleared and the thought was gone, he wasn't able to do so, which resulted in him doing his repetitive behaviors, such as his hand washing and checking on things and repeating his words to himself or out loud, to where others would look at him in a certain way and say, why is he, repeating himself often? The compulsions are defined, like I said, in 1 and 2, which is the repetitive behaviors. The behaviors of mental acts preventing or reducing his anxiety and distress was when he would when he would actually spell the word quarantine. He'd have to spell it out completely in order for him to be completely relaxed. If he was unable to remember any of the letters, he would start again and start again until he was able to. There was signs in the movie where he wasn't able to do so, and that would cause him to have a complete relapse where he would literally lock himself up in a room and not deal with anyone. And that's when his towards the end of the movie where his compulsion became even more evident. All of these things that he was exhibiting were very time consuming. It was taking more time for him to get things and be productive during the day when he was having these attacks, because he was putting more time into having to hand wash, where anyone else it would take 2 to 3 minutes. For him, it would take 5 to 10 minutes to wash his hands until he felt it was they were clean. Him not leaving the bathroom because he was afraid to touch the doorknob. If someone didn't come to the bathroom for 20 minutes, he stood there for 20 minutes waiting for them to come and open that door, so that they can use the bathroom and he can get out of it. So it was very time consuming, very distracting. There were no signs of him using any type of medication to induce any of these compulsions. These were just things manifested within his life, within what he was taught as a child. So we can rule out that any medication or drug abuse was not evident at the time for this condition to be so active. I use absent insight and delusional beliefs because he completely thought that his obsession was in fact 100% true. He felt that there was a legit fear in touching a doorknob, that he would get sick from it, or from drinking from an open bottle, or drinking from a cup, or eating food that was not in a specific manner. If the food was touching each other, he was really grossed out, and he didn't like having all those things together in one plate. He wanted things separate. So there was an actual fear for him, which gave him the belief that his compulsive disorder was, his obsessions were real. Tic-related, he often showed that when he was repeating his words, he would clear his throat and kind of do that kind of remark when he was would say something. So if he was saying, "It's time to," it's time, it's time, it's time, and he would continue, it's time, it's time, it's time, and he, it's time, it's time. Those kind of things is where the tic-related came in, because that was an issue for him, and it was something that was evident in what he was doing. The specific phobia disorder with situational, the reason why I have that as a rule out is his marked theory or anxiety about a specific situation, the doorknob, the water coming out of the faucet, drinking from a cup that he didn't see someone pour the drink. Those things would make it a fear in a situation manner. So it was a specific situation that would get him that way. Touching a steering wheel, touching the pilot wheel, someone having something on their shirt or on their clothing that would show some type of dirt or germ. Those kind of things put him in it was a situation, a specific situation that he was afraid of getting sick. And these kind of phobic fears caused immediate anxiety. You saw it in his face the minute that he would have some type of anxiety situation. His eyes would tense up. He would become like, if he was very serious or very mean or very concerned look on his face, and he would have that fear in his eyes that something was going to happen and it was going to overtake him. And you can tell just by his demeanor and how he talked and handled the situation. Also, with that situational thing was also whenever there was a camera flashing in his eyes, too many people at one thing giving him too much attention. He didn't like that. He wasn't used to that kind of thing. Even though he'd been around it for quite some time, it still affected him. The flashing of the lights, all those things scared him. And so those put him in situations at that moment that provided a fear in him and an anxiety. And so he tried to avoid as much as he could. He did have a doctor come and see him, but no one ever specified exactly what he was going through. The people closest to him just kind of moved him to a solitary room where no one around him would see, so that no one knew what was going on with him. He wasn't afraid of any kind of airplanes or elevators or heights. He loved all those things. Those are the things that fascinated him the most. But his obsession and delusional beliefs and tics and fears all prevented him from doing those things without fail. He would have to redirect himself consistently when it came to that, because of certain things that were happening at that moment that would trigger his anxiety and his compulsive obsession. Pharmacological treatment. When it comes to the OCD and the specific phobia disorder, they both can be treated the same way when it comes to medicine. I was looking at selective serotonin reuptake inhibitors, SSRIs, and which are antidepressants such as Zoloft or Paxil. These alone will not only work; he will need additional therapy in addition to taking one of these medications. And if we combine that medication with therapeutic measures, I think we'll see a better aspect of how to handle it. Psychological treatment and family-based treatment both fall under the same thing, where we can use cognitive behavioral therapy, CBT, in addition to the medication. This can be done in an individual and family therapy setting, where we would have, because of his high status in society and the things that he was doing, and them trying to keep everything just private, I would recommend that these services be done in his home, where the doctor and the therapist can come to his home to monitor him, to do the therapies with him, in his home, the cognitive behavioral therapies, and also include his wife or girlfriend, whoever he was significant with at that moment or during that time, anyone close to him, the two business associates who are also his closest friends, they would all have to be part of this therapeutic measure, in order to help him throughout, and especially when the therapist and the doctor are not there with him. They kind of understand what is going on and how to approach him and how to help him. It's very crucial that we educate all the parties involved, including Mr. Hughes, on what diagnosis he has, what it entails, and what measures we're taking, and make sure that he is on board and that the family and closest friends are on board as well in his care. Therapy will include implementing exposure and response preventions. This form of therapy would entail gradually exposing him to the things that he fears. So that would be having him drink out of a cup of milk that was poured without him seeing it, having him open up the doorknob after using the bathroom without anything on his hands other than just his hand and him opening the door. We would gradually do these things and work on each fear individually until those fears are done, until he no longer fears them and he can do them on his own. And then we'd work on to the next fear and on to the next fear, because there are multiple fears that he has. We have to take each one gradual to not overwhelm the patient as well as not overwhelm the family, taking things small steps at a time. So those are things that we will do, and the process of therapy and medication can go from anywhere from no earlier than 6 months and no later than 2 years, no more than 2 years in therapy to get him to gradually overstep. And then once those 2 years have reached, we can then come back to see what progress we've made with the patient and the family, and see how much further we need to go and what else we need to implement. Biomedical treatment. There are two types of biomedical treatment. One utilizes medication such as antipsychotics, antidepressants, anticycling agents, and hypnoaxylates. The effectiveness of these medications is about 80%. Some medications have bad side effects, so it's very crucial that we know what these side effects are, the family knows what these side effects are, and Mr. Hughes knows what these side effects are if we're going to go in this manner, so that they can see what they are, they'll know what they are when they're happening, and we'll be able to address those situations. And if we have to stop the medications, then we know what was the cause of the reasoning for stopping them. Most of the time, once you stop these medications, the obsession, the OCD will come back, and all of his fear phobias will come back. So it's very crucial that we work on those. Another type is to use medical procedures such as electroconvulsive therapy, which is also known as ECT, or electroshock therapy. This is something that is only used as a last resort, because what we're doing is we're inducing a seizure in the brain to help alleviate the effects of the mental illness. And this is often used with medication and therapy as well. So it's all in conjunction together. The bad thing about this particular type of, or the side effect to this process, is that it can have memory loss. And that's, it's not 100% that it's going to work, and it could just be more damaging. So that's always the last resort. There's also a method that they would do a surgical procedure, where they would damage or remove part of the brain, and only about one third of patients improve. So it's not a method that is used often. Not many states or countries use it, and it's a very small number of patients that have it done, and only a number of clinics that do it, and doctors that perform it. And this does require a team of neurosurgeons and psychiatrists to work hand in hand in the operating room at the time. So this is also a last resort, and this would probably be the last resort possible for Mr. Hughes if that's the direction they wanted to take, if in fact medication and CBT did not work. However, I do think that with the help of his family and friends, CBT and medication monitoring him, and being consistent with therapy is the best course of action for him, because he is aware that these things are occurring. You can tell that he's aware of them. You can see that it does bother him. So he'd be more inclined to work with it and learn from it and be successful at it, than to go a more extreme route. So that is my diagnosis for Mr. Hughes, and my week 5 assignments. I think anyone that is experiencing OCD and fear phobia, again, the best form of action would be to get the medication that is needed and the therapy, which is the CBT therapy, where we can work on each fear individually and move with and progress from there. So that's my assignment, and thank you so much.